We present the case of a 23-year-old male patient who had a history of a penetrating injury to the left eye with a firecracker. There was a sclerocorneal tear repair done elsewhere and referred for further management to our hospital. On examination of the left eye, there was inaccurate projection of rays with 10-0 nylon sutures at the temporal limbus with total hyphema. There was no view of the fundus. Ultrasound B scan of the left eye showed a high reflective echo in the vitreous cavity, suggestive of an intraocular foreign body with an extensive vitreous hemorrhage and a total retinal detachment. He underwent a pars plana lensectomy followed by a pars plana vitrectomy. As you see, there is a large metallic intraocular foreign body in the vitreous cavity, surrounded by vitreous hemorrhage. The cutter was used to remove all the vitreous which was adherent to the intraocular foreign body and released from all the adhesions from the retina. There was an extensive attachment of this intraocular foreign body to the peripheral detached retina. As the vitreous was trimmed with the cutter, you see that the intraocular foreign body gradually became more mobile. You can also see the bullous retinal detachment underlying this large intraocular foreign body. There was also the evidence of a large retinal break underlying this intraocular foreign body. A small amount of perfluorocarbon liquid was injected to protect the macula from getting damaged by the movement of this large intraocular foreign body. You can now see the optic nerve head below this foreign body. After the injection of the perfluorocarbon liquid, the vitrectomy was continued to remove the peripheral uncut gel. The foreign body now seems to be more mobile than what it was earlier. The question was that how to remove this large foreign body. There were two options, either to remove it by enlarging the sclerotomy or through the limbal route. We decided to remove it through the limbal route. An opening was made in the limbus through which an intraocular magnet was put in to see whether this foreign body was magnetic or not. However, what we realized that this foreign body was not getting attracted to the magnet. The magnet was taken out, and now we opted for putting in an intraocular foreign body forceps through the same paralimbal incision. Several attempts were made to hold the foreign body with the forceps. However, the forceps being in the left hand, which is the non-dominant hand of the surgeon, a proper grip was not achieved. So now it was decided to hold the foreign body forceps in the right hand, and it was put in through the sclerotomy. The foreign body was then grasped with the forceps and lifted up and brought into the anterior chamber. The ring was removed and a limbal incision was then made and enlarged with the corneal scissors. The foreign body was firmly held with the right hand in the forceps. Lens forceps was used to lift the corneal flap and the foreign body was now delivered out from the eye. The cornea was put back into its place, and you see this large foreign body which was taken out from this eye. The limbal section was then sutured using 10-0 monofilament nylon suture. This was followed by fluid air exchange, endolaser photocoagulation was done to the retinal break, and silicone oil was injected. The silicone oil from the left eye was subsequently removed 3 months later, and the patient regained a final vision of 624/12. This is the anterior segment photo of the left eye, and the patient still remains aphakic. This is the large conical metallic intraocular foreign body removed from the left eye of this patient successfully. Thank you for your patient hearing.